Great. It's my pleasure to welcome everyone to the final session of the day, What's New and Interesting. My name is Katherine Chilton, and I'm the Vaccine Educator at the BC Centre for Disease Control. This session features 4 presentations in which each speaker will present on their work, then address audience questions in a brief Q&A following their presentation, which is different from the previous sessions. I encourage you to submit questions using Slido and upvote questions you feel are important. So without further ado, I would like to introduce our speakers. Dr. Hana Mitchell is an infectious disease pediatrician and clinical assistant professor at BC Children's Hospital and UBC. Dr. Mitchell will share a video about talking with expectant parents about infant immunizations. Next, I will show our new webinar, Relaunching the New Immunization Communication Tool for Healthcare Providers. Following that, we have Ian Rowe, the content strategist with BCCDC and co-chair of BC's Immunization Promotions Working Group. Ian will update us on Kids Boost Immunity and tell us about Clubs Boost Immunity. And lastly, Dr. Kyla Hildebrand is a pediatric clinical immunology and allergy specialist and clinician educator at BC Children's Hospital. Dr. Hildebrand will tell us about new pneumococcal vaccines. These speakers' files are in your program, and we are very fortunate to have Dr. Mitchell, Dr. Hildebrand, and Ian Rowe presenting with us today. For the first presentation, please head over to Slido for a short poll while I welcome Dr. Hana Mitchell. Going to, yeah.
Hi, everyone. I'm also speaking to you from here in Vancouver, from the territory of Coastal Salish people. And we would like to show a video to you today that I co-developed together with Dr. Julie Bettinger. So I will call over to our AV technician to play the video, please.
Uptake rates of prenatal, infant, and childhood vaccines are below the nationally recommended levels, which puts communities at risk. How are parents making decisions about vaccinations?
Good morning, Rachel.
If you're a healthcare provider, you know the importance of vaccines. But for someone having a baby, they're making decisions early. If your patients don't get vaccine information from you, they're getting their information from somewhere.
She's having a party in there today.
Yeah, I feel her all the time now.
How's your sister's wedding planning going? Did you find a bridesmaid dress?
Yeah. I'll be the only one at the stag not drinking.
All for a good cause.
Yeah.
Any other questions today?
No.
Hey, Jade, did you get it? Did you open it? Did you read it? I just forwarded it to you.
New parents need information from professionals they trust.
It happened to my cousin's partner's girlfriend's his friend. You know, it's complicated.
Not from Steve's partner's girlfriend's best friend. Study after study shows a confident recommendation from a trusted care provider is the #1 factor in vaccine acceptance.
It's good. You're doing really well.
I just want her to be born.
Anything else come up that you want to discuss?
But those conversations need to start early. When baby isn't even here, as a care provider, you're busy. And if you're not the one to give vaccines, you may not think to bring it up.
Hey, I think your baby's hungry. Might want to try feeding her, maybe.
New parents, like all of us, are sensitive to being judged. They might not voice all their vaccine concerns or initiate a conversation.
Weight's good. 80th percentile.
Public health called. They want her to come in for her shots next month.
Great.
I mean, I made the appointment. even though I've read some things.
Don't worry. The nurses there are great. They'll have all the information there for you.
What you think is deferring to another professional may be seen as a lack of endorsement.
Oh, 2-month vaccines? We're getting them too. Oh, he's over 1 year old, but we delayed everything. 2 months seems too young to get them. Their immune system gets overwhelmed, and that's why you see those kids with all the allergies.
We don't want the shots. I made a mistake.
I understand you're nervous. Let's just talk through your concerns.
What just happened? Let's try that again. Vaccine conversations need to start early, be unambiguous, and they need to happen with you, a care provider who already has a trusting relationship with the patient.
How's your sister's wedding planning going? Did you find a bridesmaid dress?
Yeah. I'll be the only one at the stagette not drinking.
All for a good cause.
Yeah.
Speaking of shots, let's talk about vaccines.
I mean, I know they're important. I just keep seeing all these things online.
Yes, I know it can be quite overwhelming. So here's a bit more reading for you. These are based on facts, not clickbait.
Okay,
Write all your questions down and we'll go over them at your next appointment.
that would be awesome.
The main thing is to start the conversation about pregnancy and infant vaccines early. Parents may want extra time to talk things through.
You vaccinated your kids, right?
Yes, of course. Looking at the evidence, the benefits clearly outweigh the risks.
A confident recommendation is important, and so is your own experience. With these tools, you can change outcomes.
I don't think I can watch.
You're doing great.
And that success can be reinforced across providers.
So coming up is our 12-month vaccination, and that involves the MMR vaccine. Now this is a critical one.
I know, I just had a few questions.
Sure. What would you like to know?
Uptake rates of prenatal, infant, and childhood vaccines are below the nationally recommended levels, which puts communities at risk. How are parents making decisions about vaccinations?
Good morning, Rachel.
You can help turn those numbers around. And it starts with a conversation.
Hey, how are you doing?
Super creative.
Wonderful, what a wonderful video and a great reminder that immunization conversations need to start early. Thank you, Dr. Mitchell. I see that there are a few questions from the audience. Dr. Mitchell, we have 2-3 questions here.
Yeah.
The first one is, where can we access the video?
Thank you. So the video is available on the Vaccine Evaluation Center website if you go under provider resources. Also very happy to be contacted if you contact Julie Bettinger or myself directly, and we can send you the link or the file on the drive. And it should also be available on the conference website.
Great, thank you. I have another question here. How is this video being distributed or utilized?
It's been a couple of ways. So as you've probably noticed, this video has really been designed for healthcare, with healthcare providers in mind, and we based it on the data and information we got from interviews with perinatal healthcare providers and parents in BC and nationally. It's been used several ways. It's been incorporated into the national midwifery curriculum as part of their vaccine education. It's been used by SOGC, and then more locally, we've used it at training events such as academic half days and clinical skill sessions for pediatrics and other trainees. And you're certainly welcome to apply it and use it as you see fit.
Great, thanks for that. And another question here is, any handout of vaccine teaching for parents?
We didn't develop a specific handout to go with the video. We listed a couple of resources at the end of the video. And I would say actually the BCCDC has quite good information to give to parents. These were actually the handouts that we used in the video that the provider gave to mom.
Great. Thanks for that. And we do have a few more questions here. This question reads, I find these videos helpful, but I am always looking to hear the actual conversations regarding each vaccine and what the healthcare provider says. Reading is great, but watching a video or more videos tend to drive the info home better. It's more of a comment, but yeah.
Thank you. That's helpful, and maybe some food for thought about kind of other potential communication materials we can develop. So really, this video was meant to be serving as a prompt to discuss vaccines, but I agree probably some videos about specific vaccines might be helpful. And if you have thoughts about vaccines that would be particularly useful, please put them in the chat.
Okay, that sounds great. And there is another question here. What are the current data on vaccine conversations during prenatal visits?
I don't have the statistics. What we know in general is that if people are not the ones vaccinating, these discussions usually don't occur, or at least don't occur in depth. And in this particular video, we focused a little bit on infant vaccines, and infant vaccines oftentimes don't get discussed in pregnancy because that's usually a busy period where there is a lot of other things going on. So pregnancy vaccines might get mentioned, infant vaccines usually don't. And that's part of what we were trying to raise with this video.
Great. Thank you so much, Dr. Mitchell. That has been a wonderful presentation and video. We really appreciate all the work that you put into that. I believe we're on to our next presentation, which is actually myself. So next I will show a short webinar on the 2021 Immunization Communication Tool for Healthcare Providers. Many of you in public health may be familiar with this resource that was first created in 2008. This webinar will look at the new 2021 version, which has a new format, new content, evidence-based strategies on addressing vaccine hesitancy, and a more user-friendly online version. And it looks like this. And Andrew, can you please start the video? Thank you.
Welcome to an overview of the 2021 Immunization Communication Tool for Healthcare Providers. I'd like to acknowledge that I'm joining you today from the unceded and traditional Coast Salish territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. I recognize that you are joining from different parts of the province and different traditional territories, and I am grateful that we can be here together throughout this recorded webinar. I have no conflicts of interest to disclose. The Immunization Communication Tool, also known as the ICT, is a project of the Professional Education Working Group and the Communicable Diseases and Immunization Service Team at the BC Centre for Disease Control. The purpose of the ICT is to support healthcare providers with the information and tools needed to communicate effectively about vaccines and address vaccine hesitancy. The ICT was first created in 2008 and updated in 2014. In 2019, immunization providers completed a survey on the ICT, with the results informing the revisions made to the 2021 edition, which has a new format, new content, and a more user-friendly online version. There are two main sections of the ICT. Section 1 explores the complexities of vaccine hesitancy and provides evidence-based strategies to address it, as well as a new immunization communication framework. Section 2 takes a deeper dive into 10 common questions about vaccines and immunization. As well, there are 3 appendices which offer additional immunization resources. The vaccine hesitancy section examines the current literature on vaccine hesitancy and provides evidence-based strategies on how to address vaccine hesitant clients. Additional infographics were created to help better understand these concepts, including the vaccine hesitancy continuum seen on this slide. This graphic captures how vaccine behaviors and beliefs can be seen as falling along a continuum, ranging from full acceptance to refusal of all vaccines, with vaccine hesitant individuals being somewhere in the middle. These are the individuals who may benefit the most from the approaches laid out in the ICT to move from vaccine hesitant to vaccine acceptance. Vaccine hesitancy is complex, and there is no single best strategy that can address it in all situations. There are, however, many evidence-based strategies for addressing vaccine hesitancy that are recommended in the current literature. A number of these strategies are described in the ICT. In addition, these evidence-based strategies are also shown as healthcare provider tips throughout the tool, as an example shown on the right of this slide. The 5-step approach to discussing vaccines and addressing vaccine hesitancy offers a practical framework to assist healthcare providers communicate effectively with vaccine hesitant clients. This evidence-based framework was adapted from the Canadian Pediatric Society's Moving to Acceptance Education and replaces the previously recommended ASK approach. The 5 steps are as follows. Step 1, assume the person will immunize. Use a presumptive statement. Step 2, give your strong recommendation. Step 3, explore reasons for hesitancy. Step 4, ask permission to address concerns. And step 5, ask again if you can immunize. These steps are described in more detail in the ICT. When healthcare providers use a presumptive statement and give their strong recommendation, many people will consent to vaccination. However, some people will be hesitant and will have questions about vaccines. It's important that healthcare providers can confidently answer their questions. Section 2 contains information to assist healthcare providers answer some of the more common questions about vaccines and immunization. Included for each of the 10 common questions are key messages for the public, more information for healthcare providers, infographics that providers can use to help explain more complex information, and examples of motivational interviewing conversations. The responses to the common questions begin with key messages for the public, given in short and simple statements using plain language. This approach aligns with the current research, which has been shown that messages that too strongly advocate for vaccination can be counterproductive, and by providing too much information can actually increase hesitancy. In addition, the infographics can help to explain more complex information to their clients. More information for healthcare providers includes more in-depth referenced information that can be used when responding to more complex questions or for the provider's own learning. Motivational interviewing has been shown to improve vaccine acceptance with hesitant individuals. Examples of motivational interviewing were developed with the help of MI experts and have been added to the common questions section to assist providers in using this approach. The appendices provide additional information on motivational interviewing, websites with immunization stories, and resources on reducing immunization injection pain. The ICT is available online on the BCCDC website. As well, there are printed copies that have been distributed in BC to health authorities and other vaccine provider groups across the province. Check with your organization if you have not yet received your copy of the ICT. Organizations can request additional copies through the Professional Education Working Group or the Immunization Promotion Working Group members. Thank you for your time and attending this webinar.
For attending that webinar. So we do have a couple of questions. I'm going to just answer one really quickly. The question is, would this resource be appropriate for all providers, including physicians? And I would say absolutely. This resource is for any immunization provider or any healthcare provider that speaks to clients around immunizations or anticipates those type of questions. So definitely all healthcare providers. Okay, I think we'll go on to our next presentation. So I would like to introduce Ian Rowe for our next presentation.
Thanks, Kathy. So I hear a bit of an echo, so hopefully that goes away. So I'm going to talk to you a little bit about Kids Boost Immunity, give you an update, as well as a new site that we're excited about called Clubs Boost Immunity. So I'm just going to share my screen to start. And I'd like to start by acknowledging that I'm coming from the traditional, ancestral, and unceded territory of the Coast Salish peoples, and happy to work on this land in Vancouver right now in the office. So I'm just going to, sorry, let me go back. So in terms of declarations, Kids Boost Immunity is a public and private initiative. It's mostly publicly funded through the BC government and the Public Health Agency of Canada, but it's also managed through BCCDC and the Public Health Association of British Columbia. We have other partners like Public Health Scotland and HSE Ireland. We do have additional supporters from foundations to different corporations as well that help with other things like paying for vaccines, as well as some operational things that go on, but we're very clear about our goal to raise literacy, and funding from organizations in no way influences any editorial choices we make. I personally don't have any personal conflicts of interest with this as well. So onto the site itself, for those of you that are not familiar with Kids Boost Immunity, this is a BC-based project. It was developed through the Immunization Promotions Working Group, launched in 2018, is available in French and English. It's also funded nationally through the Public Health Agency of Canada. And as you can see, these are free online lessons. We have what's, I guess, new for us is that the number of lessons we've increased significantly, and we've also done a number of things to improve the site for teachers over the last year or so. I also want to just say that for those, we do target teachers primarily, but you can sign up as a healthcare provider, and many of you have. So we would encourage you, if you're connected to a school, certainly if you know a teacher, tell them about it if you like what you see. And if you like what you see today, please sign up, and then you can see all the lessons for yourself. I'll give you a super quick overview of what we've done. I'm just going to log in. And two of the main things we've done in the last year is revamped our teacher center. And this is to provide lesson plans, professional development, and user guides in these 3 sections. This is to make it as easy as possible for teachers to use the site. Lesson plans are a really critical part of that. So we have lesson plans on a number of our topics here, as you can see. And these are meant to make it easy to teach the lesson for the to the students. And so this one is for National Day of Truth and Reconciliation. So the main other, I guess, thing that we've improved a lot on, I hope, is the lessons themselves. So last year we had 100-ish lessons. We've almost doubled that in the last year. And the lessons really, an important learning for us early on was teachers are not, we're certainly interested in vaccine literacy and raising vaccine literacy. That's kind of the raison d'etre of the site. However, if we did that all the time, then the site would have limited utility. So we do have a number of lessons and lesson topics in areas that are aligned to the curriculum and what the teachers might want to teach. And these have, I guess, an indirect connection to vaccination. An example of that would be the Black History Month lessons that we've posted for February, and the Immortal Life of Henrietta Lacks is an example here, as you can see. Each quiz has a, each lesson has a quiz, and if the student gets 80% on the quiz or more, they earn a vaccine for UNICEF, and that's the kind of the sort of local and global approach that we've taken to this issue. We found that it's really a really effective way to get kids interested and engaged, because they're not just going to talk about an issue, they're actually going to do something about it as well by earning real vaccines for kids. So there are a number of topics here, as you can see, and each of these topics has a series of lessons in them. And the teacher can easily browse and see which topic areas they're in, which subject areas they're in. It's also broken down by grade, grades 8 and 9, 10 plus, etc. And so just quickly perusing here so you can see, I'm not gonna have time to go into any of these. The only one I do want to show you is, I'm just gonna give you a sense of the breadth and scope here. We developed new ones for influenza last year. And the one I wanted to look at was something called How to Handle Your Shots Like a Champ. I think I just went over. This is a lesson we first introduced a couple of years ago, and it's really designed around how to get kids to be prepared for routine vaccination day in school. Now, COVID has kind of pushed that all around, and now everyone's been scrambling a little bit this year and last year to get the shots, but this is really designed around that. And so you can see here, there's a link to the lesson plan. The teacher would see this. This would be some instructions and recommendations on how to teach the lesson. But we worked with the CARD program, and the pretty straightforward lesson for the kids. They can go through it. And there are interactive bits in there, there's videos that they can look at. They can, turn over different cards, etc. There's a game that they can do to see if they are smart. And oh, I'm not that smart, so I can retry, or I should see the solution. And then at the end of the lesson, they can go and there's another one here. They can take the quiz at the end of the lesson. So this is something we're trying to promote to healthcare providers, for those of you that are connected to schools. We really, and that are going to be ramping up vaccinations in the spring, to encourage the teachers that to try to take this lesson for the grades that are applicable. This one's for 4, 5, but we have them for other ages as well. Certainly for grade 6 and 9. And if it's 7 and 10, for those of you who are going to be doing it for those grades. This is a great way to kind of take the mystery out of some of the vaccines that they're going to be getting, to help reduce anxiety, create a positive dialogue in the classroom, etc. And, it's about, for us, the big idea around this was having the right intervention at the right time, in the right place. And what better time than the week before, for example, your vaccine day is scheduled, maybe in between when the consents are being sent home and they're sent back. So that's Kids Boost Immunity. And then the other site I just want to spend a minute to show you on is Clubs Boost Immunity. And I think I'm going to need to share that screen. Here we go. So this is Clubs Boost Immunity, and this is based on a partnership we've had with the Boys and Girls Clubs of Canada. And it's a new site we've developed with them to pilot in 28 of their clubs across the country, including Cranbrook, which is doing well this so far, second on the all-time leaderboard. It's based on the same premise as Kids Boost Immunity, with lessons. We call them activities. And the essential difference is we've broken them down into levels that are age appropriate. And the only thing I I'd sort of leave you with on this is that the levels are different in the sense that we've broken it down to level 1, which is actually younger than we do for kids boost immunity. Level 1 is designed for 6 to 8 year olds, which is very young, and they're really activity group-based games essentially that the kids do together. And we hope that if we're successful in this, that we'll be able to import what we've learned into kids boost immunity to bring it down to grades 1 to 12. Right now it's grades 4 to 12. So
Great. Thank
that's
you.
it.
Thanks, Ian. That's so amazing. Thank you and your team for the amazing work on this resource. I think we are going to go straight to our next presentation, just in interest of time. So I would like to welcome Dr. Kyla Hildebrand.
Hello. All right. Well, thank you very much to the organizers for inviting me to speak with you today. My name's Kyla Hildebrand, and I am a clinical associate professor at the University of British Columbia in the Department of Pediatrics. And I'm delighted to speak with you today about new pneumococcal vaccines under review in Canada. All right, so just in terms of disclosures, I don't have any really. They're just put up here. I've had some honorariums for some talks I've given moderating sessions at conferences locally and nationally. I have no financial support, and I will use generic names only for the vaccines mentioned in this presentation. Okay, so our current vaccines that we have for pneumococcal disease in British Columbia and Canada are listed here, and I'm sure most of you are very familiar with them. My plan for today was really to walk you through some really great epidemiological data that we should be proud to have from our colleagues and researchers here in British Columbia. And then that forms the basis of knowing, are we meeting the needs of disease burden within our province and within Canada? And then lastly, I'm going to review the ACIP guidelines on the pneumococcal vaccines that are newer, that have been recommended in the United States. So for today, we'll start off here. Our current vaccines for pneumonia are twofold. So we have the PCV13, which is a 13-valent pneumococcal conjugate vaccine, and it's indicated for anyone 6 weeks of age and older, and it's been part of our routine pediatric schedule since 2010. We also have a polysaccharide pneumococcal vaccine, which is indicated for those 2 years of age and older with medical conditions, as well as being part of the routine schedule for older adults. It's been around for a long time, though, in fact, since 1989. And it's important to have these 2 different vaccines because they activate the immune system in different ways. So with the pneumococcal vaccines, what in fact are we aiming to prevent? Many of you will know that the non-invasive pneumococcal disease is quite common within the community, both in pediatrics and adult populations, including community-acquired pneumonia, otitis media, and sinusitis. I'm going to focus my session today, however, on the invasive pneumococcal diseases, including bacteremia, sepsis, and meningitis, because they have such a significant impact on our healthcare system and burden of disease. This is the population that we are most concerned for when it comes to invasive pneumococcal disease. We have good data to show that adults over 65, young children under the age of 2, immune-compromised individuals, which is my patient population that I look after, those with chronic medical conditions, those who are homeless and living in crowded living conditions. And I would also add to my list here, individuals living in northern communities, because there are disparities in incidence and prevalence of invasive pneumococcal disease in northern parts of our Canadian population. So let me run you through the first of 3 studies that I want to bring to your attention. And I think they highlight beautifully the research that's being conducted here in British Columbia. These next few slides will highlight some key findings. And in this paper, it looks at what happened to invasive pneumococcal disease rates after the PCV13 vaccine was introduced into our routine schedule in British Columbia. This graph here highlights 2 time points of PCV immunization implementation. You can see in 2003, PCV7 was introduced, and then later in 2010, NACI changed their recommendations and suggested replacing PCV13 and switching out the PCV7. And although it may look that the total incidence of invasive pneumococcal disease is relatively similar from 2002 to 2015, what I did want to highlight for you is the yellow bar, which shows the rates of invasive pneumococcal disease that's related to PCV7. So once we implemented that vaccine, those serotypes sort of disappeared and faded into the background. The trade-off is that we've had these other serotypes emerge as being more causative for invasive pneumococcal disease. If we look at serotype between 2002 and 2015, you can see here the serotypes broken down based on what vaccines cover which serotype. So the area to highlight for you is here in the non-PCV13 serotypes. We have, since the implementation of PCV13, an emergence of 22F serotype as being sort of the main cause of invasive pneumococcal disease in British Columbia. So in summary, what this data shows us is that we know the vaccines work. We see fewer of the vaccine serotypes causing disease, but newer serotypes emerging as they take over as the main cause of IPD in BC. This second study I want to highlight for you is from the Canadian Immunization Research Network, and it presents the epidemiology of invasive pneumococcal disease in BC and Ontario, but by age group. And this is really important because when new vaccines are considered, we need to think about who would best benefit from their use. This study referenced a cohort of just over 27,000 individuals in both Ontario and BC. And for this definition, IPD was defined as a laboratory-confirmed streptococcal pneumonia infection from a sterile site. What I want to highlight in these two figures are the burden of disease by age. So the top graph here represents the age group specific incidence of IPD according to the pneumococcal conjugate vaccine program periods. And that's represented by all these little different shades of green that you see clustered by age grouping. What I hope you'll notice is that between 2002 and 2018, the burden of disease was highest amongst the age categories of 65 to 74, 75 to 84, and 85 and beyond. This lower graph represents the serotypes that were causing this invasive pneumococcal disease between 2007 and 2018. The very dark green shading you see at the very top of those bars represents the non-vaccine type pneumococcal disease serotypes. And we know that we are seeing an increased incidence of IPD due to serotypes 3, 19A, 7F, and 22F. And lastly, let's look at the annual incidence of IPD in BC, because I think that's really important to know how common is it and what are the numbers and how does it change over time. I'll draw your attention here to the red line, which represents the non-vaccine serotypes, which have actually increased over time from 1.5 to 2.4 per 100,000 individuals. These rates here are adjusted by age group and also by sex. There's also been an increase in the polysaccharide pneumococcal vaccine 23 serotypes, as you see by the green line, and it's been steadily increasing from 2.6 to 3.0 per 100,000. Overall, this data has shown us that we have really solid epidemiological data to support the incidence rate of IPD. In British Columbia, it's 12 per 100,000 individuals. So let's talk about the new pneumococcal vaccines that are coming up the pipeline. There are two, PCV15 and PCV20. I've listed the serotypes here, but if you're more of a visual person like I am, I'm going to put them up here in a graph format so it's easier to compare them. You can see here that there's a lot of overlap between PCV13 and PPV23, but there are also differences. The newer vaccines that are under review are listed here. And I've highlighted for PCV15, the 2 serotypes that are unique, including 22F and 33F. And for PCV20, we see those same 2 serotypes in addition to 8, 10A, 11A, 12F, and 15B. All right. Let's go on and talk about the Advisory Committee on Immunization Practices from the United States. So for those of you who don't know, this is sort of the equivalent of NACI in the US, and they recently made recommendations for both of these vaccines for their immunization programs. When looking at their data, you can see here the incidence of invasive pneumococcal disease in adults over 65 was actually much higher than what we see here in Canada at 24 per 100,000 population. When you look at which serotypes were causing disease, just drawing your attention to the 35% were those that were found in the PPV23 vaccine. And then others are arranged between 27% were PCV13 strains, and then others were captured here as strains that were unique to either PCV15 or PCV20. ACIP used an evidence to recommendation framework and applied a grading of recommendations, assessment, and development and evaluation. And this is the same approach that we're using at NACI as we look at these newer vaccines as well. I want to take a moment here just to quickly highlight the immunogenicity data, because these 2 vaccines are unique in that there's no efficacy data. We typically see that when we're asked to review new vaccines. However, we are only provided with immunogenicity and safety data. So just to quickly summarize here, for PCV15, you can see they were comparing doses compared to PCV13. The population that they studied is listed here. And just to note that there were some immune deficient individuals in the population studied. And overall, in terms of immunogenicity, they met non-inferiority criteria, which is a must. And they also showed that there was a statistically significant greater response for serotype 3, and they had a higher percentage of seroresponders for many of the shared serotypes between the 2 vaccines. For PCV20, this was a study looking at 2 groups of individuals, so either 60 to 64 years or all adults over 18. And again, what they found was that those who received PCV20 had really had met non-inferiority criteria for all the 13 shared serotypes, but there was in fact a slightly lower GMT and lower percentage of seroresponders for 12 of the 13 shared serotypes. So this is one of the sort of disadvantages of PCV20 compared to PCV15. And when they compared it with PPV23, the PCV20 recipients had a higher mean titers and higher percentage of seroresponders of 6 of the 7 shared serotypes. In terms of safety, there were no major signals that emerged. The most common adverse events were what we typically see with most vaccines, sort of pain at the site of injection. The severe adverse events that were reported were very comparable between the control or the placebo group that was used, and no severe adverse events or deaths were attributable to the vaccine. So what did ACIP recommend? They did 2 recommendations. One was age-based, in that they recommended one of these pneumococcal vaccines to adults over 65 years. And then they also had a risk-based recommendation for those adults who have underlying medical conditions or risk factors that haven't previously received a pneumococcal vaccine. So there were 2 options that they put forward. Individuals could receive either a PCV20 in isolation, or they could receive the PCV15 in series with the polysaccharide pneumococcal vaccine 23. The dosing interval, I think, is worth noting as well, that if you are using the PCV15 and the polysaccharide 23 version, that they recommend a 1-year period in between the 2 vaccines. Certainly, this can be shortened to a minimum of 8 weeks between the 2 vaccines for those who require more urgent immune protection, such as those who are immune compromised or have CSF spinal or CSF fluid leaks or cochlear implants. And for those who may have received a PPV23 vaccine in the past, it's recommended that they could receive either the PCV15 or PCV20 greater than 1 year after the last PPV23 dose. And certainly there was no need to repeat another dose of the PPV23 after the PCV15 was offered. So just coming up to my last few slides here, I'll just sort of put this up. I'm not going to go over it in detail, but just to show that there are some advantages and disadvantages to both of these proposed recommendations and schedules. And I think that, we're really looking forward to reviewing these with Health Canada and with NACI. So in summary, we have evidence that pneumococcal vaccines work in preventing invasive pneumococcal disease, and we have great BC data to be proud of. We have Canadian data indicating that IPD remains high, even despite 8 years of a national pediatric PCV program. We know that there are non-PCV13 serotypes that are causing IPD and that are on the rise, including 22F. And lastly, these 2 new vaccines are currently under review with Health Canada. And on that note, I will just thank you for your attention and take any questions.
Wonderful. Thank you for this interesting presentation and important update on pneumococcal vaccines. We do have one question. Is there a sense of when conjugate pneumococcal 15 and 20 valent vaccines may be approved for use in Canada?
Yeah, I can say that we're currently reviewing the data and using the evidence to recommendation framework at the moment. Our working group has been struck for this pneumococcal vaccines, and we anticipate completing our review in the next few months. It may be by the fall that there is more information to share.
Wonderful. Thank you so much, Dr. Hildebrand, and thank you to all of our presenters through this session. And I would like to say that this concludes our session on what's new and interesting. So thank you again, and I will now hand it over to Dr. Monica Naus.